the spironolactone is it blocks the dihydrosterone receptors on the sebaceous gland. It's also able to induce the synthesis of androgen precursor in adrenal gland. The adverse event has been discussed. What we have to well understand and to remember is that with spironolactone in acne, we use low doses between 50 milligram daily and maximum of 150 milligram daily. It's completely different than what we use in all people as diuretic, whereas it between 200 and 300 milligram daily. Adverse event, as you can see here, it's when you have higher dose, 200 milligram, it's significantly more than what we use in acne. You can have menstrual irregularity. In any case, you can reduce them if you have, by oral contraception. No problem definitively with potassium. So you can see the probiotics which are used, and you can see the result compared to placebo with an improvement of at least one severity grade, which is confirmed in 50% of patients week 12 in the probiotic arm, compared to only 30% in placebo arm. It's just preliminary result, so we need to confirm this result with oral probiotic. So now if we move to grade 2 to grade 5, that means more severe acne, here clearly, as we can see, it's the place of the anti-androgen, metformin and spironolactone. About metformin, just to remember, the main indication is polycystic ovarian syndrome, hyperpilosity, overweight, irregular period, and what is very important, increase of anti-Mullerian hormone. You know that it is important to treat this patient because they can have metabolic syndrome, diabetes, cardiovascular disease. And it has been shown in this systematic review and meta-analysis that metformin may be useful and safe alternative to oral contraception, particularly in obese women. And here you can see the acne score, which is significantly reduced after metformin use in different studies which has been performed. So here is a very interesting randomized trial. So comparing doxycycline 100 milligram daily to metformin 1 gram daily. And just at the topical level, the patient used benzoyl peroxide. And you can see that finally, the results are very similar in the two arms. So similar result between doxycycline and spironolactone, but what is very important to take in count is that you have a significant quicker effect with doxycycline, with a plateau. So it's slower effect with metformin, but at the end you have a more significant decrease of lesion, both inflammatory and non-inflammatory lesion. It's why it's interesting to combine metformin and topical treatment, specifically fixed combination, to have a quicker effect. And the management, you have to give 500 milligram once daily during the first week, then 1 gram during the second weeks, and then it's followed by 500 milligrams 3 times a day, 1.5 gram for weeks 3. It means that you increase slowly metformin if you have any adverse event, you stop to increase. The maximum daily dose have to be 2,500 milligrams. So the adverse events are mainly non-cutaneous, generally mild to moderate, concerning skin lesion. It has been just observed, so rare leukocytoplasmic vasculitis. And now if we move to spironolactone, so the interest of the spironolactone is it blocks the dihydrosterone receptors on the sebaceous gland. It's also able to induce the synthesis of androgen precursor in adrenal gland. The adverse event has been discussed. What you have to well understand and to remember is that with spironolactone in acne, we use low doses between 50 milligrams daily and maximum of 150 milligrams daily. It's completely different than what we use in all people as diuretic. There is it between 200 and 300 milligrams daily. Adverse event, as you can see here, so it's when you have higher dose, 200 milligrams, significantly more than what we use in acne. You can have menstrual irregularity. In any case, you can reduce them if you have, so by oral contraception. No problem definitively with the potassium. So you don't have to control the potassium, so the cadmium during the treatment. Other side effects, but they are very rare on only grade 1, nausea, hypotension, very irregularity in the rules I mentioned previously, very rare, and gynecomastia. Thromboembolic risk, definitively, you can see that it's very recent paper shows that you have no increased risk of deep vein thrombosis or pulmonary embolism with spironolactone. So this treatment is safe. Obviously, you can use associated with contraception, and you have to stop, obviously, immediately if you are pregnant. So in this context, we decided for the first time to compare spironolactone and the doxycycline, as you can see. Doxycycline, so 150 milligrams daily, and benzoyl peroxide for 3 months, because in France, we cannot use this treatment more than 3 months. Then it means so to obtain a follow-up of 6 months. We decided to have 3 months of doxycycline, 3 months of placebo, and for spironolactone, so it was used for 6 months. In both arms, topical benzoyl peroxide. The women were stratified for the contraception, and we want to demonstrate that spironolactone was superior to doxycycline in the treatment of acne in adult females. So the main objective was at 6 months, so to demonstrate that we have a significant decrease of the score AFAS-1 and the score AFAS-2. So if the AFAS-1 score had decreased by less than 2 points or no change, and AFAS-2 was no change or greater than 1, so it was decided that it was inferior. On the contrary, it was considered that the patients were successful, and in the doxycycline arm, it continued to be alone, and in the spironolactone arm, it continues spironolactone alone. So, as you can see, after 4 months of treatment, we are at the limit of significativity, but at 6 months, definitively, it is demonstrated that spironolactone is 3 times more efficiently than doxycycline. So you can see that it's the same thing that metformin. So the treatment takes time to be efficiency, but you will see the curve just after, when after 4 months, 6 months, it continues to decrease the acne lesions. What was the method of contraception? There is no modification of the efficacy. So this trial has been published concerning the adverse event. We have no severe advance, even no hyper and spironolactone. We are 16. So success compared to 13. But where you are at 6 months, we are 32 success compared to only 17. And that is obviously very significant. And here you can see on the curve that we start at 4 months to have a difference between spironolactone and doxycycline, but it increased at 6 months, 9 months, 12 months, and you have a plateau with doxycycline for inflammatory lesion, non-inflammatory lesion, and even for the quality of life. Here, same thing, if you take the AFAST score, global AFAST score, you can see, so the difference. You have the difference in score 1, so it's appear at 4 months, it increased at 6 months, and even after. And that is exactly the same thing for the ECLA score, which has been used for the TRANQ and AFA score 2. So, the conclusion is that it is the first double-blind clinical study demonstrating the superiority of low dosage spironolactone versus doxycycline. Very good clinical relevance. Here today, spironolactone has no marketing authorization for the treatment of female acne, even in the United States, where it is prescribed for more than 40 years. It can be considered an alternative to isotretinoin in case of failure or if you have a contraindication. Just in France today, so we try to have an authorization of compassionate access for permitting to the dermatologists to use in their daily practice the spironolactone. And we are waiting for the answer. Here you can see the results, both on hyperseborrhea, acne lesion, and even on scar. So just to finish here, concerning the use of topical spironolactone in the future, and here you can see that you have a significant difference compared to Dapsone. I think it will be of real interest in the future. And just to remember, for in adult female acne, it's better to have 3rd or 4th generation of oral contraception, because 1st and 2nd generation, progesterone is transformed in androgen, so it induces acne lesion. Just concerning isotretinoin, this very recent study demonstrates that it could be of interest even in a patient with polycystic ovarian syndrome. So I think it's interesting because it's new. And finally, remember that you have to take and to check the cosmetic is really very important. Use cleanser with a pH around 5. So moisturizing cream, obviously non-comedogenic in the morning, and obviously sunscreen, so against UVA and blue light to avoid post-inflammatory hyperpigmentation. And just to remember that is an holistic approach in the management of adult acne, which is very well demonstrated by this recent paper, so showing that a low glycemic index diet, so decrease acne lesion, and at the same time, as you can see, decrease testosterone and the protein, the binding protein of the testosterone. So just it is important to think that quality of life is very important in adult acne, and so we have a very crucial role in the management of adult acne. Thank you so much.
Dear colleagues, let me thank the organization for the kind invitation. The topic I'm going to talk today is acne and antibiotic resistance. Are dermatologists really guilty of that? This is my conflict of interest. So the topic of antibiotic resistance is a big word. So in order to avoid to get lost, we will focus on a specific point. Antimicrobial resistance means refers to bacteria, viruses, fungi, parasites, and antibiotic resistance is just focused on bacteria. Bacteria are offended when antibiotics come, and they try to create defense. So the activity of antibiotics is different on bacteria, but if we focus on the activity of tetracyclines, macrolides, and nicotinamides, which are used in acne, they are inhibitors of the protein synthesis of the bacteria. And bacteria create different types of defense against antibiotics. Just to focus on the way of resistance of staphylococcus on tetracyclines, they create an increased expression of efflux pumps. You have to remember that there are many bacteria which are intrinsically and genetically resistant to antibiotics, like Cytobacter causarii, just to give you some examples, Enterobacter cloacae, Klebsiella pneumoniae, Serratia sessions. These are resistant to all these type of antibiotics without a previous contact. We, as dermatologists, prescribe antibiotics to our acne patients, both topical and systemic ones. Among the topical antibiotics, we know that clindamycin and erythromycin are the most frequently used, and in some countries, minocycline, quinolones, and dapsone are available. Among oral antibiotics, tetracyclines are the first choice, and doxycycline and limacycline are preferred to minocyclines and tetracyclines. And salicylate is a newcomer, and it is available in some countries. Second line are macrolides. Third line, metropin, sulfamethoxazole, and in some selected cases, clindamycin and dapsone. But what is the aim of an antibiotic in acne? Antibiotics reduce C. acnes in number, so indirectly reduces the inflammation which is induced by C. acnes. But it is well known that inflammation in acne is not just produced by C. acnes. There is a sort of inflammation which is independent on C. acnes. So antibiotics are able to work also on this type of inflammation, not related to C. acnes. I think it is important to remember that when we prescribe antibiotics to our patients, we create resistance, but in some bacteria, not in all bacteria. But we have to remember that we can create resistance to the bacteria which are on the body of our patients, internally or externally. I'd like to focus on this point because sometimes it is generalized. And you have to remember that we do not create resistance to bacteria which are outside of the body of our patients. Now move to some practical consequences of bacterial resistance acquired by bacteria in acne patients. So we have on one side situations which are directly related to acne. On the other side, we have situations which are not directly related to acne. First point, situations directly related to acne. We have seen that C. acnes may induce inflammation. And when the bacteria has become resistant to the antibiotic, so the anti-inflammatory effect of that antibiotic is no more effective. We have already seen this concept, but I'd like to stress it. So when the inflammation in acne is not induced by C. acnes, the anti-inflammatory effect of the antibiotic continues. So we have to keep separated these two ways of. What are the bacteria which are involved in acne? On one side we have Cutibacterium acnes, and the other side Staphylococcus epidermidis. They are both commensals and part of the stable resistant microbiome. C. acnes is a gram-positive anaerobe and aerotolerant bacterium, and it is usually a good guy, but we know that sometimes good bacteria may behave as bad bacteria. In some other situations, bad bacteria may behave as good bacteria, such as the Staph aureus on our nose. And C. acnes may induce deep, severe infections in a different type of anatomic areas, in the rheumatological field, in orthopedic field, and also in others. Staph epidermidis is a gram-positive, coagulase-negative staphylococci, and this again is a usually good guy, but sometimes may induce severe, deep infections. What is important in the correlation between these two bacteria is to keep a balance, because one bacterium controls the other, and the balance of these two is good for the homeostasis of the skin, and is good for acne. When C. acnes increases in number, and the phenotype of acne which may produce inflammation are increasing, the risk of acne is increased. What is the prevalence of C. acnes antibiotic resistance? In this study, it has been demonstrated that there is a quite wide variation over the years, and in terms of range, we move from 15% in Singapore, 2007, to 94% in Spain, 2000. And this is, in general, C. acnes resistance to any type of antibiotic. And again, you see there are some countries around the world where the susceptibility to antibiotics in acne, in the microbiome of acne, is very, very low, like in Mexico, Spain, France, and Egypt, where the antimicrobial resistance rate is over 75%. But what is the antibiotic with the highest resistance rate? In these systematic review, we see that erythromycin and clindamycin have a quite low rate of susceptibility, and there is a quite high level of susceptibility for tetracyclines. And again, in these systematic reviews coming from England, the rate of resistance to macrolides, erythromycin, and lincosamides, such as clindamycin, is definitely higher than that of tetracyclines. And let me show you some very recent papers where the same concept is confirmed. So tetracyclines are very rarely produce resistance, and erythromycin, clindamycin may induce resistance more frequently, around 50–60% of the situations. So the answer to the question, what is the antibiotic with the highest resistance rate, is erythromycin and clindamycin. Another question, Does the prevalence of resistance change over time? This is, in my view, a very interesting study, which has been managed by Alison Layton, Professor Layton from Harrogate and York, and his colleagues demonstrated that comparing the prevalence of resistance of C. acnes to tetracyclines, erythromycin, and clindamycin over the years, between 2004 and 2013, they have seen that there is no change in the prevalence of resistance. So, and this country is a country where colleagues pay much attention on the behavior in terms of prescription and management of antibiotics in acne. This is a study from Australia, and there is another demonstration that no difference in terms of prevalence of the acne occurs over the years. After 10 years, 1997 and 2007, these colleagues found no difference in terms of prevalence of resistance in C. acnes. And let me talk about a point which is, in my view, of great interest. The topic is the reversibility of resistance. And I found really few studies on that, at least in acne. This is one of those. And this colleague have demonstrated that after the end of the treatment with the antibiotics, they have got 15 patients with resistance, and after more than 4 months, they have seen that the number of patients with resistance was 0. So the acquired resistance could be reversible. So the question was, does the prevalence of resistance change over time? The data seem to demonstrate no increase. Now we move to another point. The situations which are not directly related to acne. We have an acne patient which have been treated with systemic and topical antibiotics. He has got a bacterial infection. And the first point is the infections are due to bacteria already present in the body. And these bacteria got resistant to antibiotics used for acne. So in terms of management of that bacterial infection with the same antibiotics which have been used for acne, maybe the management of these infections could be more difficult. On the contrary, if the patient has got an infection due to bacteria which were not present in the body and they had no contact with antibiotics that the patient used for acne, there is no more difficulty in management this type of infection related to the use of antibiotics for acne. So now the question is, are acne patients treated with antibiotics more susceptible to infectious diseases during treatment and in the coming months? These systematic reviews focalize on only two cohort studies, which are these ones. And the authors found serious imprecision they quoted as low quality for both of the studies. And the conclusion was that there is a lack of high quality evidence on the relationship between oral antibiotics for acne treatment and subsequent antimicrobial sequelae. Let me focus on this study, which has been one of the most frequently mentioned study. The title is Antibiotic Treatment of Acne May Be Associated with Upper Respiratory Tract Infections, 2005. And the odds of URTI among users was quoted about 2.15 times greater than in non-users. The comment of the editorial was that we have to remember that just 10% of the URTI are due to a bacterial source, 90% to viruses. So in conclusion, the editorial stated that what are the implications of this study for clinicians? The findings do not yet justify a change in current management and behavior. Personal experience, I didn't publish this data. We checked 50 patients, adolescents treated with oral tetracyclines versus controls. 6 months of follow-up together with GPs and pediatricians, we found no difference in terms of incidence of infections in these two groups. So the answer to the question, are acne patients treated with antibiotics more susceptible to infectious diseases during treatment? And in the coming months, the available data show no significant increase in susceptibility. Another question. Do acne patients treated with antibiotics find more difficulties to be treated in case of bacterial infection? World Health Organization stated that, at least in Europe, around 33,000 people die as a direct consequence of infection due to bacteria which are resistant to antibiotics. And this is a very high number. What are the most serious, most dangerous bacteria which are implicated in that? Carbapenem-resistant Enterobacteriaceae, such as Klebsiella, Enterococcus, Faecium, E. coli, methicillin-resistant Staph aureus, in the community-acquired infections, hospital-acquired, and livestock-acquired. And in addition, Clostridium difficile infections and other gram-negative bacteria such as Acinetobacter species and Pseudomonas aeruginosa. The WHO published in 2022 an antibiotic book. They took into consideration all the infections which can be managed on one side by the primary health care, and on the other side, infections which can be managed in the hospital facilities. Lot of infections. Let me just show you as an example the way the colleagues published this data. This is referred to pharyngitis, description, and different choices of therapy. The same with impetigo, zebra, and cellulitis. But I don't go through obviously all the details. I have a final slide which summarizes all these points. So we have again the management of cellulitis zebrae. We have community-acquired pneumonia. We have different types of treatment. We have hospital-acquired pneumonia, and this is the list of all the diseases which have been described and the type of antibiotics used in acne which are involved in this type of diseases. This is the long list, but the final slide which summarizes the point is this one. Regarding tetracyclines, in details, doxycycline has been used just in the treatment of community-acquired pneumonia in mild cases. And doxycycline is not the first choice. There are at least 3 antibiotics to be used before, and the second choice, the second choice is shared with the combination of amoxicillin and clavulanic acid. And as a second choice, doxycyclines can be used in the management of cholera. So never as a first choice. Regarding macrolides, they are used more frequently, definitely more frequently. Pharyngitis, acute infections of GI tract, and severe community-acquired pneumonia, cholera, enteric fever, and sepsis and septic shock. Clindamycin in necrotizing fasciitis and sepsis and septic shock. Cotrimoxazole just in acute infections of GI tract. So we see that these antibiotics are used in the selected positions. What can we expect from the treatment of an acne patient with systemic antibiotics? We can expect around 60–65% of improvement. Just to show you an example of one of my patients treated after with 3 months of systemic limnocycline and topical retinoid before and after. So the question was, do acne patients treated with antibiotics find more difficulties to be treated in case of bacterial infections? No, in particular regarding tetracyclines. We have other types of antibiotics which can be used to treat this type of infections. So tetracyclines are used very, very rarely. Macrolides a little more frequently. So it is preferred, in my view, to use tetracyclines. So we are at the conclusions. We have seen that the use of antibiotics, both topical and systemic, stimulate bacteria to create a defense to the antibiotic, and they can become resistant. The practical consequences in terms of clinical aspects is that there is a potential reduction of efficacy of antibiotics in acne. We have seen a high level of resistance to macrolides and nicosamines. We have seen a low level of resistance for tetracyclines. We have to consider and to remember that the persistence of level of resistance over time. So, I mean, there are some data which demonstrate that the level of resistance seems not to increase. And this is an interesting point. I think it is interesting to go more deeply on this part here. It is reversibility of resistance. We have few data. So, acne patients treated with antibiotics, there is no demonstration of increased risk of bacterial infections. We have seen the most dangerous bacteria, which are Enterobacteria, MRSA, and so on. So the potential reduction of efficacy in bacterial infection is clinically relevant. Tetracyclines are used just in mild cases of community-acquired pneumonia as a second choice, shared, and in cholera. Macrolides are more frequently used. Should dermatologists then feel guilty while using antibiotics in acne in 2025? I think no, at least not that much, but the adequate antibiotic stewardship must be followed. And another topical or systemic antibiotic should be used as monotherapy. We have absolutely to use BPO together with topical antibiotics and also with systemic antibiotics. Treatment longer than 3 months should be avoided as much as possible. And after 6-8 weeks, it is important to evaluate the clinical evolution of the disease, because in case of no good results, we have to think about another solution. So please do not consider that in my presentation I'd like to support the use of antibiotics in acne, in particular the systemic ones. I think that antibiotics should be used as less as possible. And so what are the effective therapeutic alternatives to the use of antibiotics? Because we can say we prefer not to use antibiotics, but we have to offer an alternative. The alternatives are topical specific treatments, antimicrobial peptides, bacteriophages, vaccines, probiotics, light therapy, hormones like spironolactone, isotretinoin. So the fighting between systemic antibiotics and the isotretinoin, which one should be used as first option is long story. So I think it is an interesting point, but I leave the question open right now. So let me thank Lisa, Natalia, Talita, the dermatologists which are working with me, Marco, which is an infectivologist, Dr. Candy and Gavassi, which are veterinarians, and let me thank all of you for your attention. Thank you.
Good day, my name is Dr. Johannes David. I'm a dermatologist and a dermatopathologist from the Philippines. And I'm going to talk about rosacea in skin of color, highlighting proper recognition and management. I do not have any potential conflict of interest in this presentation. From January 2021 to October 2024, we have seen a total of close to 30,000 patients, and 70% of which are rosacea cases as compared to 18% which are acne vulgaris cases. And for a very long time, there's always been an erroneous perception that rosacea is rare in skin of color. Well, basically because it is difficult to detect erythema in darker skin phototypes. So it has been underdiagnosed, misdiagnosed, undertreated, and suboptimally treated. For the recognition, our goals are to familiarize with the 2019 ROSCO criteria differentiate it from acne vulgaris, identify comorbidities, and further investigate on atypical presentations. And we always have to highlight the updated rosacea diagnosis and Roscoe classification from 2019, consisting of diagnostic phenotypes, in which only one is required for the diagnosis, major phenotypes, in which any two are required for the diagnosis of rosacea, and secondary phenotypes, which include burning, erythema, edema, and dryness. We should always remember that for the diagnostic phenotypes, only one criterion is required for the diagnosis of rosacea. So it may either be number one, persistent facial erythema, and these are just some examples in brown skin, and phyma or phymatous rosacea, which can either be metaphyma or enlargement of the glabella, blepharophyma, which is enlargement of the under eye or the zygomatic area, rhinophyma, enlargement of the nose, and natophyma, which is enlargement of the chin. This is the typical combination of rhinophyma and natophyma among post-adolescent women presenting with rosacea. This is rhinophyma among men in an adult on the left and a teenager on the right, which is also characterized by multiple sebaceous hyperplasia. This is untreated rhinophyma at age 50 and above, where you see enlargement of the glabellar area, the under eye area, the nose, as well as the chin. These are examples of inflammatory rhinophyma among teenagers, so recurrent papules and pustules, usually on the nose. These are examples of non-inflammatory rhinophyma among adults, inflammatory and non-inflammatory autophyma with enlargement of the earlobes, inflammatory and non-inflammatory natophyma. Phototypes. So it has been underdiagnosed, misdiagnosed, undertreated, and suboptimally treated. For the recognition, our goals are to familiarize with the 2019 Roscoe criteria, differentiate it from acne vulgaris, identify comorbidities, and further investigate on atypical presentations. And we always have to highlight the updated rosacea diagnosis and Roscoe classification from 2019, consisting of diagnostic phenotypes, in which only one is required for the diagnosis, major phenotypes, in which any two are required for the diagnosis of rosacea, and secondary phenotypes, which include burning, erythema, edema, and dryness. We should always remember that for the diagnostic phenotypes, only one criterion is required for the diagnosis of rosacea. So it may either be number one, persistent facial erythema, and these are just some examples in brown skin, and phyma or phymatous rosacea, which can either be metaphyma or enlargement of the glabella, blepharophyma, which is enlargement of the under eye or the zygomatic area, rhinophyma, enlargement of the nose, and natophyma, which is enlargement of the chin. This is the typical combination of rhinophyma and natophyma among post-adolescent women presenting with rosacea. This is rhinophyma among men in an adult on the left and a teenager on the right, which is also characterized by multiple sebaceous hyperplasia. This is untreated rhinophyma at age 50 and above, where you see enlargement of the glabellar area, the under eye area, the nose, as well as the chin. These are examples of inflammatory rhinophyma among teenagers, so recurrent papules and pustules, usually on the nose. These are examples of non-inflammatory rhinophyma among adults, inflammatory and non-inflammatory autophyma with enlargement of the earlobes, inflammatory and non-inflammatory notophyma or involvement of the chin. These are examples of inflammatory notophyma characterized by papules and pustules on the chin, and non-inflammatory notophyma, which is characterized by scarring of the chin. This is panphyma or in phymatous rosacea, also characterized by multiple sebaceous hyperplasia. And in this patient, there has been a very long history of ocular rosacea. These are examples of persistent centrofacial redness in darker skin phototypes, in which the redness can be highlighted or demonstrated by more sophisticated medical imaging. This is persistent centrofacial redness in lighter skin phototypes, persistent facial erythema in a Filipino male patient, which is highlighted by medical photography. Inflammatory papules and pustules in darker skin phototypes, mostly involving the nose and the chin. Inflammatory papules and pustules accompanied by centrofacial erythema in lighter skin phototypes. Inflammatory papules and pustules in lighter skin phototypes, and you'll appreciate the before and after photos with improvement in the redness and facial puffiness. We also have to highlight that rosacea fulminans in previous years has been misdiagnosed as papulopustular acne vulgaris, but there are slight differences. So rosacea fulminans is also called pyoderma faciale or leary, characterized by papulopustules, purplish nodules, as well as confluent abscesses. And it may form fistulae, so the patients may develop serous, seropurulent, or mucoid discharge. So the clues to the diagnosis include post-adolescent age, so patients in their 20s to 30s. It may also occur among pregnant women. It has a sudden onset, so very quick onset, and it may involve the face completely, particularly the chin, the cheeks, the forehead, and the nose. We should also be able to recognize rosacea and concomitant Demodex infestations when you see scales on overlying areas of papules and pustules or erythema. And if we do a biopsy, we can readily identify the Demodex mites. This is also an example of rosacea and Demodex infestation, which is actually Demodex folliculitis. And on histopathology, we can demonstrate the Demodex mites within the follicular infundibulum. Demodex infestations sometimes usually present also as papulonodular rosacea and often recalcitrant to topical treatment. So these are rare cases of unilateral papulonodular rosacea. And in a proportion of cases, Demodex can be demonstrated on skin punch biopsies. These are examples of the typical granulomatous rosacea, which is quite difficult to treat. So on the left is a case of papular rosacea, which is actually granulomatous rosacea on histology. And on the right, we see a form of granulomatous rosacea, which is evolving into what is called milia and plaque. Morbihan disease, which is a solid edema of the upper part of the face, can also be seen in patients with chronic rosacea. So these are examples in lighter skin phototypes. And this is an example in brown skin where we appreciate the phymatous rosacea. And in this patient, because of metabolic syndrome, he also has acanthosis nigricans. But if we examine him closely, we will observe the enlargement of the earlobes, which is otophyma, and enlargement of the nose, which is rhinophyma. Scalp rosacea is becoming more and more interesting. So the patients usually present with underdiagnosed recurrent redness and pustules and papules on the scalp. So it's usually chronic with features of facial and extrafacial rosacea and quite responsive to rosacea treatment. So for the treatment goals, we should be able to control inflammation, address the redness, the papules and pustules, and treat the Demodex infestation, prescribe the proper skincare, avoid trigger factors, and promote photoprotection among patients, and manage acute flares. Exercise caution with certain procedures such as chemical peels, lasers, and energy-based devices. The goals of treatment is to promote clearance of lesions, avoidance of concomitant PIH or post-inflammatory hyperpigmentation. Long-term suppression of erythema is usually desired by both clinician and the patients, but is most often difficult to achieve. And then we set realistic expectations for the timeline of improvement during the course of the disease. It is also very important to educate the patients about the chronicity of the disease and its long-term management. And yes, we should be able to we should exercise caution when doing procedures. For topical treatments in most Asian countries, so these are available. So brimonidine, metronidazole, and azelaic acid, they're quite effective, especially for the papulopustular type of rosacea. But recently, ivermectin cream, 1% is very promising because is only it does not only address Demodex infestation, it has also a very good anti-inflammatory effect. For the systemic medication, especially for the papulopustular type of rosacea, the tetracyclines are very effective. So I usually prescribe limecycline or doxycycline. And in some cases, not responsive to antibiotics, no, we can prescribe low-dose isotretinoin. So azithromycin is a very good alternative antibiotic to doxycycline. And in a Korean study of around 67 patients, azithromycin 500 given thrice weekly is almost comparable to doxycycline 100 milligrams once daily for 3 months. Isotretinoin is also effective on phimosis rosacea, especially if we want to prevent the fibrotic phase of phimosis rosacea. And it has better results in younger patients. And the Global Consensus Panel, or the ROSCO panel, indicates isotretinoin as treatment in inflamed phyma in an early stage with a high degree of recommendation. For skincare, we are advised to prescribe gentle, non-alkaline, fragrance-free emollient cleansers once a day in the evening. Silicone-based moisturizers or those which contain dimethicone. Light water-based cosmetics and physical sunscreens are also recommended. So we try to avoid alcohol-based cleansers and non-silicone-based moisturizers and chemical sunscreens. For environmental modification, of course, we should teach our patients to live a healthy lifestyle with an anti-inflammatory diet or correction of the metabolic syndrome, gentle skincare, and we advise them to avoid trigger factors such as extreme temperatures, sunlight, spicy foods, alcohol, exercise, stress, menopause. Daily UV protection is usually advised to our patients with a broad spectrum sunscreen with a minimum SPF of 30 and with a silicone-based vehicle. So these are just some examples of rosacea cases treated with different modalities. In this patient, he was given low-dose oral isotretinoin for 6 months, rosacea skincare, and metronidazole cream twice a day. In this patient, he was treated with low-dose isotretinoin for 6 months, rosacea skincare, metronidazole cream twice a day, with significant improvement in the redness and the appearance of papules and the pustules. In some cases, they do well with just metronidazole cream for flare up of the redness twice a day or OD, and of course photoprotection for 5 years. And this patient has been monitored for 5 years, and now she's doing very well. So there's also a decrease in the centrofacial redness with just metronidazole cream and photoprotection. In younger patients who are good candidates, they do well with low-dose isotretinoin and metronidazole cream. They also do well with the vascular lasers. In my practice, I use the 577 nanometer Pro Yellow laser more often. So in this patient who was not given oral isotretinoin, so I just prescribed rosacea skincare, metronidazole cream twice a day for flares, and of course photo protection with a significant reduction in centrofacial redness. And for granulomatous rosacea, which is usually very difficult to treat in this patient, she responded well to topical ivermectin cream 1%, and there has been complete resolution of her granulomatous rosacea at week 8. Okay, these are before and after pictures. So for the conclusions, a thorough clinical evaluation of rosacea is a requirement in skin. Clear and long-term treatment. So thank you very much for your kind attention. So good day. My name is Dr. Johannes Dairit. I'm a dermatologist and a dermatopathologist from the Philippines. And today I'm going to talk about acne fulminans, rosacea fulminans, and acne conglobata, which are considered severe forms of acne, which may be morphologically similar, but may have different underlying pathophysiology and hence different treatments. I do not have any potential conflict of interest in this presentation. So for the learning objectives, number 1 is to define, describe, and differentiate acne fulminans, rosacea fulminans, and acne conglobata. And number 2 is to discuss management of the active and the scarring phase of these 3 conditions. So the typical acne vulgaris, usually the mild forms, are observed in 95% of teenagers and young adults. The onset is usually in puberty, but may also begin in childhood. The primary lesion is the comedones. However, the comedones may evolve into papules, pustules, nodules, and the cysts. More commonly, it affects the face, the neck, the chest, the back, and the shoulders. We should all remember that the hallmark of the typical acne vulgaris are the open and closed comedones, which we also call blackheads and whiteheads. And most dermatologists usually follow these treatment recommendations published in the Blue Journal in 2016, which classifies the severity of the acne as mild to moderate and severe forms, and the following treatment options are advised or recommended. So for example, in some patients, such as in this 13-year-old male presenting with comedones, papules, and pustules, treated with only topical fixed-dose combination adapalene and benzoyl peroxide, we notice an improvement after a few months. However, comparing to his twin with comedones, papules, and pustules treated with the same topical fixed-dose combination plus low-dose isotretinoin for 6 to 8 months, the improvement is more significant or dramatic. So this is an update on the treatment recommendations for mild, moderate, and severe acne from 2024, which is also published in the Blue Journal. And these are the following strong recommendations. So oral isotretinoin is recommended for severe forms of acne. The antibiotics such as doxycycline, minocycline, sarecycline, limecycline are also recommended, especially to treat papules and pustular lesions or inflammatory lesions. However, doxycycline is preferred over azithromycin. Topical benzoyl peroxide, retinoids, and antibiotics are still the cornerstone of topical treatment, and azelaic acid, which is the topical form, is advised for skin of color. However, in some cases, they may present in a more challenging clinical presentation. Take this case, for example, of an 18-year-old male with moderate acne vulgaris requiring higher dose of oral isotretinoin and with an additional topical trifaritin cream. And in this 16-year-old male with severe acne vulgaris with sensitive skin syndrome, also required a higher dose of oral isotretinoin, only mild acne skincare because he is reacting to the conventional anti-acne topical medications. However, the most severe form of acne vulgaris is called acne fulminans. It has a sudden onset, usually affecting young males, with painful ulcerating and hemorrhagic lesions, with or without fever, and polyarthritis, with or without bone lesions and lab abnormalities. And this condition is usually resistant to the usual acne antibiotics such as doxycycline or limecycline. It is similar to acne conglobata, but there are no pseudo or polyporous comedones. So this is an example of case of acne fulminans, a 17-year-old male previously diagnosed with acne vulgaris with a sudden appearance of papules, nodular cystic lesions on the face, trunk, and extremities 2 weeks post-COVID mRNA vaccine booster injection. He also had low-grade fever and diarrhea. At the time of examination, the patient was febrile and presenting with tender hemorrhagic nodules and pustules, confluent pustular lesions on the submandibular area, with similar lesions on the trunk. He also developed tender cervical and axillary lymph adenopathy, and he had joint pains. The recommended treatment and management of acne fulminans, since it is non-responsive to the usual antibiotics for acne vulgaris, is usually a combination of oral corticosteroids and isotretinoin. Oral corticosteroids is usually given at high doses, 0.5 to 1 milligram per kilogram per day for the first 2 weeks, then until all lesions fully resolved. Then low-dose isotretinoin is started when all lesions have healed or is not in the active phase anymore. Potent topical steroids lead to a faster response, and LED blue light phototherapy twice a week for 6 weeks is useful in the severe inflammatory phase of the condition. So this patient was given clindamycin 300 milligrams for 2 weeks, methylprednisolone 16 milligrams OD, which was tapered for 1 month. And then when the inflammatory lesions have subsided, then he was given oral isotretinoin for 6 months. And these are before and after pictures, especially after 2 years of follow-up with minimal residual scarring. During the active phase, the patient was also exposed to LED blue light phototherapy twice a week for 6 weeks. And now we move forward to rosacea fulminans. So it usually happens in patients with symptoms of rosacea. And in brown skin, this is an example of the typical rosacea patient. Consulted several dermatologists, already underwent different acne from CO2 laser from anti-acne medications such as retinoids and benzoyl peroxide, also develop immediate redness on chemical peels, and most of the time, these patients need help. So the usual question that I ask is that what makes you red or what makes your face warm? So it is heat, is it sunlight, emotions, exercise, alcohol, skincare, menstruation, and with the use of modern medical imaging devices, we can see the centrofacial redness in this patient, which is typical of rosacea. So this is an example of papulopustular rosacea in a 55-year-old female, 60-year-old female also presenting with nodular lesions, and a 52-year-old male with a previous history of centrofacial redness as well as rhinophyma. However, the most severe form of papulopustular rosacea is called rosacea fulminans, which is also called pyoderma faciale O'Leary, consisting of papulopustules and coalescent purplish nodules as well as abscesses, which form confluent fistulae. It may have a serous, seropurulent, or mucoid discharge, involving mostly post-adolescent women. It may also affect pregnant women. It has an abrupt onset, and it may affect the complete face, the chin, the cheeks, the forehead, and the nose. And please take note that most of the papules and pustules are red and overlying an erythematous background. So this is an example of rosacea fulminans in a 20-year-old female with a history of persistent centrofacial redness, but with an abrupt or sudden appearance of painful papules and pustules on the face for 3 weeks. So these are the recommended treatment and management of rosacea fulminans. So number one is systemic prednisolone. Although in my practice, I don't usually give oral steroids for rosacea fulminans because once you stop it or you discontinue, then relapses is fairly common. I usually start isotretinoin when inflammation has abated to maintain remission over 6 to 12 months. The other antibiotics such as oral tetracycline, erythromycin, dapsone, and azithromycin are also effective. So the LED blue light phototherapy is very useful for rosacea fulminans, especially in the severe inflammatory phase. And the patients would usually have an exposure twice a week for 6 weeks. So isotretinoin is still off-label for moderate to severe papulopustular rosacea. A low dose is recommended for 4 months with slow and progressive reduction until we reach microdosing as maintenance treatment. Otherwise, the papules and the pustules usually relapse. However, laboratory control and assessment of pregnancy is always important. So these are the topical treatments available in the market. So metronidazole, azelaic, and topical ivermectin are reserved for papules and pustules. So this is the same patient who was treated with low-dose isotretinoin for 6 months, azithromycin for 6 weeks, and topical metronidazole cream, showing improvement also on the redness on the centrofacial area, and very much improvement in terms of scarring. So this is another example of rosacea fulminans in a 19-year-old male. So the patient was given initially limecycline for 2 weeks and then doxycycline for almost a month, then low-dose isotretinoin for 1 year, topical azelaic acid, limecycline for 2 weeks, then doxycycline, then low-dose isotretinoin for 1 year, and topical azelaic acid, with marked improvement in redness and skin texture, and also improvement in scarring. We now move forward to acne conglobata, which is a chronic form of acne involving the face, chest, back, and the buttocks. It may or may not be associated with hidradenitis suppurativa. It may consist of nodulocystic lesions, draining sinuses, hypertrophic and atrophic scars are common. And a clue to the diagnosis are the polyporous comedones, which may be found on the face, or in the case of folliculitis decalvans on the scalp. And in most patients, there's usually accompanying rosacea and rhinophyma. So these are pictures lifted from the internet of the polyporous pseudocomedones of acne conglobata. So this is a 15-year-old male presenting with nodule cysts and scarring. So this is acne conglobata on the face, but in some patients, they also have folliculitis decalvans characterized by painful or tender pustules as well as scars. These are the scars of acne conglobata, which may be atrophic or hypertrophic or keloidal. And in the pathophysiology, we normally see a lymphoplasmacytic infiltrate with or without presence of neutrophils. So for the recommended treatment and management of acne conglobata, isotretinoin is also advised for 20 to 28 weeks or even longer. Minocycline, tetracycline, doxycycline are also excellent options, but should not be given concurrently with isotretinoin. Dapsone and oral steroids are reserved for severe cases. For severe acne conglobata associated with hidradenitis suppurativa, this is recommended. Clindamycin 300 milligrams twice a day, plus rifampicin 600 milligrams OD for 10 weeks. And these are before and after pictures of an acne conglobata patient. So the therapies for acne scarring, whether the patient developed atrophic or hypertrophic scars from acne fulminans, rosacea fulminans, or acne conglobata, these are the therapeutic options. So subcision, TCA cross, punch excision, and elevation. injectable fillers, chemical peels, dermabrasion, microneedling, lasers, and energy-based devices. For rosacea fulminans, especially for the post-inflammatory erythema and the PIH, we usually prescribe treatments with a pulse dye laser or the tabletop new generation vascular lasers. So severe atrophic scars respond better to ablative lasers such as the carbon dioxide laser or the Ergomeag laser, while mild to moderate atrophic scars can be treated with less invasive modalities such as non-ablative fractional lasers and RF devices such as fractional microneedling. So superficial box scars are usually responsive to energy-based devices with significant improvement. These are the treatment options for the different types of acne scars, such as ice pick scars, rolling scars, and box scars, with the following degrees of recommendation. So these are just some examples. So this is a 27-year-old male with actinic lobata scars treated with 4 sessions of CO2 resurfacing laser and TCA cross, with noticeable improvement in the appearance of the scars. Another patient who had acne vulgaris with 4 sessions of CO2 resurfacing laser and TCA cross, with significant improvement in the appearance of the scars. So what are the take-home messages in this presentation? So first of all, it is important to recognize acne fulminans versus rosacea fulminans versus acne conglobata, because treatment may slightly differ to maximize control of the disease. And because of the overlapping features of these 3 conditions, they still have to be properly defined and differentiated. But definitely, we observe that the 3 conditions can cause significant scarring on the face, neck, back, and the jawline. So it is very important to intervene as early as possible with optimal treatment to minimize scarring. So thank you very much for your kind attention.
Dear colleagues, it's a great pleasure for me to be with you for the Guinea World Skin Health Day Congress. I'm Professor Samira Zubiri from Algeria, and today I'm gonna to share with you updates on adult female acne. Adult female acne is an acne that appears in women aged over 25 years old with specific clinical aspect evolution. It's a disease frequently encountered in women, with several studies describing a prevalence ranging between 12 and 50%. 46% of the women with acne are aged between 25 and 30 years, then the prevalence decreases among the ages. This association is linked to the sebaceous secretion, which is increased during puberty, then decreased after. According to the onset of acne, we describe 3 subtypes. The persistent subtype, reported in 55% of the patients, it's an acne persisting from adolescence to adulthood. The second subtype is an acne with a flare-up during adulthood. And the third subtype is the late onset acne, reported in 41% of women. According to ethnicity, we describe 51% of patients among the white and Caucasian ethnicity, followed by the Black, African American ethnicities in 24% of the cases, and rarely the Hispanic and the Asian ethnicity. The pathophysiology of acne in adult women is similar to adolescents. Traditionally, we describe 4 major factors in the pathophysiology of acne: hyperseborrhea, follicular hyperkeratinization, Cutibacterium acnes and its role in the chronic stimulation of the immune innate system, and the genetic predisposition. Here are main factors involved in the pathophysiology of acne: the hyperseborrhea, the role of Cutibacterium acnes, and there is a hyperkeratinization of the infrainfundibulum with the effect of pro-inflammatory cytokine, mainly interleukin-1 alpha, but also androgen has a role in the eye hyperkeratinization. The second major factor is the inflammation and the role of Cutibacterium acnes. In this study, there was a comparison between the types of Cutibacterium acnes in adult women and adolescents, and as you can see, there is not a difference in terms of types of Cutibacterium acnes in the two, and there are non-microbial factors such as hormonal skin changes or environmental factors involved in the pathophysiology of. We know that androgens are the major stimulating factors of the pilosebaceous unit, but acne is not associated with abnormal plasma androgens. In this study, you can see the levels of androgen in the group with acne and the control group is similar. There is no difference in terms of testosterone or other androgens. It's an end organ hypersensitivity with an increased number and an increased sensitivity of the androgen receptors of the sebocyte and keratinocyte, an increased peripheral hormonal conversion with normal circulating levels of hormone. This study evaluated the tissue production of androgen named 3-alpha-diol-G, and as you can see, the metabolite of androgen in tissue is higher in the group with acne compared to the group with control. And to explain the preferential location of lesion of acne in the face in women, this study evaluated the levels of dihydrotestosterone in the face and in the back, and as you can see, the levels are 15 times higher in the face compared to the back. Also, the activity of the enzyme, the 5-alpha reductase, converting testosterone into dihydrotestosterone, this enzyme is higher in the face compared to. The genetic background is a major factor in the pathophysiology of acne because the family history of acne is reported in 70% of the cases. You can see in several studies his familial history of acne. Although acne is not a heritable condition, but there is a polygenic transmission with inflammatory genes and genes of steroidogenesis. This study evaluated the trigger factors in adult female acne, and here you can see that the most important trigger factor is stress. Stress is reported in several studies, in several papers in the literature, according to the changing lifestyle of the mother. And chronic stress will by activating the hypothalamic hypophyser system and producing some substance activating the pilosebaceous unit. But stress is not involved in the severity of acne, but there is a role of the stress in the place of acne according to this study, as you can see here in the table. The second major factor in this study was the use of cosmetics. The concept of cosmetic acne was coined by Kligman, and several studies reported the role of androgen in this adult female. Here you can see that there is a more frequency of using foundation in the group of women with acne, but several cosmetics are reported, such as fairness cream, foundations, facials, sunscreen. The results are controversial between the studies because nowadays we know that the ingredients of the product are non-carcinogenic. What are the clinical aspects of adult acne? Two major forms: the inflammatory form with papules, pustules, and rarely hyperseborrhea, and the retentional form with blackheads, microcysts, and hyperseborrhea. There is a table comparing the two forms, the inflammatory form affecting 58% of the females with papules, pustules, and the seborrhea is not always present, and the retentional form with a microcyst and open comedon and an increased seborrhea. Here are some pictures of the inflammatory form with these pupils and these pictures of the retentional form with microcysts and open comedon. In both forms, acne is mild to moderate and a preferential location on the lower part of the face, mainly the mandibular region, the chin, the cheeks, as you can see in this of these patients. When comparing the location of acne between female and male, you can see that there is a significant difference between female and male for the facial location. Several studies report this facial location. Here, for example, first cheeks and chin, then forehead and trunk location. In this study, you can see that there is location on the face, but also on the forehead and the trunk acne. Several studies have reported that the truncal acne has a greater impact in the quality of life. Here, for example, the two colors, the blue for the facial acne associated to the truncal acne and the orange for the facial group only, and you can see that there is a greater impairment of social activities, clothing, daily activities, physical symptoms when the facial location was associated with the truncal location of acne. In adolescents, acne affects the T-zone, mainly the forehead and the nose with multiple comedons. In the adults, it's the U-zone with cheeks, chin, and the perioral region. Several studies report perimenstrual flares in adult female acne. It's reported frequently according to the edema of the pilosebaceous unit during this phase of the menstrual cycle. Is there any indication of laboratory investigation or hormonal investigation in adult female acne? According to this guide to clinical practice with this algorithm, if there is signs of hyperandrogenism such as hirsutism or alopecia, there is an indication to investigate the blood levels of hormone, testosterone, sulfate of dehydroepiandrosterone, luteinizing hormone, and follicular stimulating hormones. This investigation must be performed during the first period of the cycle. If there is no signs of hyperandrogenism, we start treating this acne. What is the treatment of adult female acne? The treatment is similar to adolescent acne with topical treatment for moderate to mild to moderate acne with retinoids for retentional form, alone or associated with peroxide of benzoyl or antibiotics and azelaic acid. The systemic treatments for the severe forms of acne or the forms that failed to conventional first-line treatments. These systemic treatments are retinoids, antibiotics, androgen receptor blockers, such as the association of ethinylestradiol and acetate de cyproterol, spironolactone, and the association of estrogen and progesterone. Let's talk about spironolactone. What is the mechanism of spironolactone? The first one is a competition with testosterone and dihydrotestosterone. It acts by decreasing the level of sex hormone binding globulin, and it degrades the cytochrome P415 cofactor necessary for synthesis of testosterone. Several studies in the literature reported the efficacy of the treatment with spironolactone. Here, the study of Koenig and collaborator in 2008 reported an improvement in 58% of the patients. The study of Charny reported an improvement in 58% of the patients, or Park reported a response in 78% of the patients. Here you can see for the blue color the patients cleared, and you can see at 12 months, 18 months, and 24 months, most of the patients are cleared after the use of spironolactone. Spironolactone is a safe drug with minimal adverse effects. It can be considered a therapeutic option in healthy women of any age, but it's still an off-label use in acne. The adverse events are irregular menstruation in 30% of the patients, breast tenderness, reduced libido, dizziness, nausea, headache, or fatigue. What about hyperpotasemia? Hyperpotasemia is rare, less than 1% in women aged between 18 and 45 years old. It's evaluated at 16% in women aged more than 45 years, and there is no laboratory testing in healthy women aged under 40 years old. What are the potential benefits of spironolactone in the treatment of acne? It reduced the need for systemic antibiotics, potentially reduced antibiotic resistance of Cutibacterium acnes, and it's a safe drug with minimal adverse effects in healthy women. It's not phototoxic, and there isn't need for routine additional tests, especially in healthy women aged less than 45 years. It's recommended to use doses ranging between 50 and 100 mg in acne for a duration between 3 to 24 months. What are the indications? For comedonal acne, the mild form will be managed by topical treatments, azelaic acid, topical retinoid, such as adapalene or tretinoin, and benzoyl peroxide. For the severe form, this is an indication to treat by oral tretinoin. For the inflammatory forms, papillopustular acne, the mild form are managed by topical treatments. The moderate form are managed by the association of topical treatments to systemic treatments. The systemic treatments are antibiotic or hormonal treatments. The severe form is treated by the association of topical treatment and systemic treatments such as antibiotics or hormonal treatments or oral isotretinoin. In conclusion, adult female acne is increasing in terms of prevalence with a specific and different clinical presentation from acne seen in teenagers with a greater impact on quality of life, and the treatment is similar to acne in adolescents. Hormonal treatments with spironolactone is a good alternative, and isotretinoin is recommended in severe cases. And thank you for your attention.
I hope you all are enjoying this session, and now I'm going to speak on disorders of hypopigmentation, a practical approach and insights. I have no conflicts of interest. I'm going to be talking about dysfunction of the melanocyte, be it less melanocytes, no melanocytes, or decreased transfer of melanosomes to keratinocytes. I'm going As we did with hyperpigmentation last year, we're going to talk about diffuse, circumscribed, and linear, and in the case of hypopigmentation, guttate. We're going to also have a marquee diagnosis, be it OCA or total vitiligo. I pick OCA, and I will explain why. Either post-inflammatory hypopigmentation or vitiligo, depending on the degree of pigment loss, realizing that there can sometimes be a spectrum, as well as linear nevoid hypopigmentation, and as I said before, IGH. We will start with diffuse. So here are examples of patients with oculocutaneous albinism. There can be a mismatch between age and degree of photo damage. You can see that solar elastosis on the posterior neck of this patient. However, the patient is only in her 30s, and so there is a mismatch or disconnect. In addition, when you see individuals of African descent who have these large lentigines in photo damaged skin, you know that most likely they have pathogenic variants in the P gene. You will also see the strabismus, and you can also see Afrocentric hair in a patient who is lightly pigmented, again, a mismatch. Remember the O and OCA, because even if you don't have access to genetic analysis, you can have the ophthalmologist tell you that the eye findings are consistent with albinism. And here you can see a woman from Puerto Rico who has Hermansky-Pudlak syndrome and multiple actinic keratoses and squamous cell carcinomas. Now, when excising those squamous cell carcinomas, it's important to realize that she will have a bleeding diathesis due to platelets dysfunction. And here's the reason that I pick OCA rather than widespread vitiligo as my marquee diagnosis. And that is because of the periorificial pattern of pigment loss. One gets a pseudomelasma-like pattern. In addition, it is rare to have a patient spontaneously have total depigmentation. In fact, when they have widespread disease that is unresponsive to therapy, the treatment is depigmentation of the remaining small areas of pigment. It is important to have in your head the two most common types of OCA, yes, but it is not necessary to memorize every type. What you need to know is where to look for additional entities so that you can go through a checklist of what other signs you should be looking for. So in your head, the first 2 to 3 entities that are most common. After that, where to look up the information. For circumscribed, we have most commonly post-inflammatory hypopigmentation, followed by vitiligo. Now, one thing we have to deal with is the idea that nevus depigmentosus is a misnomer. Why? Because when we speak as dermatologists about depigmentation, we oftentimes in our head think of a patient who has had complete pigment loss. While that is not the exact definition of that term, it is one that is in our heads. And as you see here, it is clear that there is not complete pigment loss. Rather, the lesions are tan in color due to partial pigment loss. In addition, you know you're a dermatologist when you look at several of these lesions and know that they are predetermined at birth, that there is no external force or external disease leading to this pattern and post-inflammatory hypopigmentation. The big question when you have a patient with post-inflammatory hypopigmentation, or what you think is that entity, is whether or not to do a biopsy. The 3 that are clustered together, I did not do a biopsy for. That is widespread seborrheic dermatitis in a young man, pityriasis alba, and then seborrheic dermatitis with lesions elsewhere outside of the anogenital region in a baby. Now, all of these respond, well, I should say the seborrheic dermatitis responds well to therapy. The pityriasis alba is really a waiting game using emollients and mild topical corticosteroids. For that, there is no magic answer. But in the case of the young man, you would consider asking about risk factors for HIV because the seborrheic dermatitis is widespread. Nonetheless, those patients did not have a biopsy. Were they not to respond to therapy, then you could reconsider that decision. The two patients, however, on the other side of the slide, did get biopsies. Because why? Because I had a wider differential diagnosis. However, the patient who has pityriasis lichenoides chronica, I have with arrows pointing to the lesions that I would biopsy, only biopsying one because they have a similar appearance. Do not biopsy the hypopigmented lesions because you may not get an answer. Rather, go for the lesions that have some erythema, some red-brown color, and perhaps some scale. The other patient has a wider differential, which includes sarcoidosis. It included hypopigmented mycosis fungoides. It could include even leprosy in a patient who comes from a region with leprosy. But in this case, I chose to do 2 biopsies because I had different morphologies. Again, looking for the lesions that have the most inflammation, the most scale, and the most in duration to get the answer. In this case, it was hypopigmented mycosis fungoides. And here are a few other examples of that entity and the biopsy. Now, sometimes you're confronted with the patient who only has hypopigmented lesions. In that case, you need to step back and turn all the lesions pink, red, or red-brown, depending on the skin phototype, and then look at the distribution pattern, the size of the lesions, the shape of the lesions, to give you an idea if were they to be inflammatory, what your differential diagnosis would be. And sometimes you have to be patient, waiting for an inflammatory lesion to arise, telling the patient to please come in when they do. But medicine is biology, not chemistry. And you can see here classic vitiligo in the genitalia, but the other 2 patients have widespread atopic dermatitis with complete depigmentation or amelanosis of the skin. I think if you want to be more precise, you can use the terms hypomelanosis or amelanosis to describe decrease versus absence of pigment. And we have amelanosis in sites of severe atopic dermatitis. Now, whether that represents Kebnerization of vitiligo or the fact that the inflammation was so severe that it destroyed the melanocytes is a matter of debate. In addition, when you have patients with discoid lupus erythematosus, the lesion may look completely amelanotic in the center, but if you do a biopsy, there's still some pigment in the epidermis, but the combination of the sclerosis of the dermis plus the marked decrease in pigment of the epidermis gives the optical illusion of complete pigment loss. But occasionally you will see people with early vitiligo, or sometimes it's been there for months and it's tan vitiligo. So again, because it's biology, not chemistry, you have to be prepared for the occasional patient with tan vitiligo and the occasional patient with complete amelanosis in sites of inflammation. What about linear? Well, I prefer the term linear nevoid pigmentation rather than saying that a patient has hypomelanosis of Ito without systemic abnormalities. In addition, there are some patients who will have both tan stripes and brown stripes, and so you end up giving a very long name to something that could be simplified as linear nevoid pigmentation. Here are examples of that disease. You can see that it can cross the midline. Number 2, you cannot always predict who has extracutaneous manifestations, be they CNS, musculoskeletal, and occasionally cardiac in the case of brown stripes, and ocular for both. So it turns out that the patient whose arm you see is the one who had extracutaneous manifestations. But again, you can see that the pigmentation loss is not complete, but the pattern follows Blaschko's lines and lets you know that what you have is mosaicism for decreased pigment production in those stripes. Now, the majority of patients will have no abnormalities or minor musculoskeletal abnormalities. With regard to the developmental delay possibility, by age 2 years, you should be able to clarify whether or not there's any extracutaneous manifestation of the CNS. And the reason I think that dermatologists do not particularly care for tan stripes is because it can be due to a number of etiologies, from extra chromosomes to ring chromosomes to translocations to deletions, and therefore it doesn't have a clean etiology the way, say, oculocutaneous albinism does. So again, facial dysmorphism and extracutaneous manifestations, you move towards genetic analysis. There are a few single genes with linear hypopigmentation, but what I have for you in green highlight is the fact that these patients, or I should say children, if you're making the diagnosis early on, will have dysmorphism of the head and they will have developmental delay. They're all neurologically impaired of all of these. So it isn't as if the patient has no abnormalities and you're wondering, do they have these entities? No, they have facial dysmorphism plus or minus the developmental delay, and it can be severe. So therefore, fairly easy to diagnose. So when we approach a patient with linear leukoderma, the entire middle has already been reviewed. If there is absolutely no pigment in the stripe, you can consider segmental vitiligo. Now, I'm not a believer in the idea of the entity of congenital vitiligo or vitiligo present at birth. I think some of those patients, though rare, may have mosaicism for piebaldism. But the idea of having congenital vitiligo either doesn't exist or is exceedingly rare. But I do have to make the notation that some of the patients who have tan stripes, you may not see them at birth. It's only after there's an increase of pigment in the skin after the first few months of life or sun exposure that you may see the tan stripes. The most important thing when evaluating a patient with tan stripes is to side-like the lesion. Roll the lesion in light because you're looking for elevation or depression. And let me explain. Elevation, we're looking for lichen striatus in that occasional patient with a hypopigmented epidermal nevus. Whereas with depression, as you can see here, we're looking for stage 4 IP or Gold syndrome. Now, Menkes carriers in general would be the only entity where you would perhaps miss it, but by taking a family history, there would be a family history of early childhood deaths in the male patients. So here are examples of a hypopigmented epidermal nevus, and you can see that it's subtle. And in this case, it was epidermolytic hyperkeratosis, and you can also see 2 examples of lichen striatus and more darkly pigmented skin that presents as tan stripes. But were you to sidelight these lesions, you would note that there was elevation within the stripes. Now, I don't advocate biopsying lichen striatus. We know that it can spontaneously go away over a year or so, but I like to show the CPC. Here's an example, 2 examples of Gold syndrome. While the fatty herniation or fatty hamartoma is the one everyone remembers because of the histology of fat in the dermis, it's actually that cribriform atrophy that's seen in the vast majority of patients. Only about half may have the fatty changes. In addition, you can see those 2 changes, as well as hypopigmentation, hyperpigmentation, and telangiectasias within the stripe. So there are 5 entities that can occur in a stripe. You may only have 2, you may have 3, you may have 1. But it's important to realize that there are 5 types of lesions that can occur within the stripes of a patient with Gold syndrome. The distinction that I like to make is that the hypopigmentation looks as if someone took a paintbrush and made a swirl, whereas the hyperpigmentation has the appearance of tiddlywinks. Now, it's come to my attention that younger people do not know what tiddlywinks are, so here I show you examples of this game. So I want you to look at that woman who has breast asymmetry and notice the difference between the hypo and the hyperpigmentation. Stage 4 IP, which is most commonly on the calf, and is a permanent change in a patient who is a patient with IP. A classic example is a child thought to have herpes zoster, newborn, and indeed they have stage 1 IP. Now, stage 1, 2, and 3 are temporary or transient, and that's because within the stripe, you have increased risk of apoptosis, and then the skin dies in that area, and the normal skin comes in from the two edges and replaces it. And you can replace the epidermis with its pigmentation. But what you can't reproduce in the stripe by having normal skin move in is hair follicles. And if you look within the stripes of stage 4 IP, there are no eccrine glands and there are no hair follicles. And for that reason, you cannot reverse stage 4. You may not see it till the child begins to make hair follicles in uninvolved skin. And that slightly elevates the skin because of the mass of cells that surround and involve a hair follicle. And so what you have is a decrease or depression, but it's only because the uninvolved skin is elevated. And for that reason, you may not see it until a child is older. And the most common location, as I said before, is the calf. So if you suspect IP in a baby, it is very important to look at the mother's calves. Now, guttate is our last area. And we always think of IgH, of course, but none of these patients have IgH. So there is a differential diagnosis. This is guttate lichen sclerosis. This is pityriasis lichenoides chronica. PLC can fit in both the guttate and the circumscribed, depending on the size of the lesions. You have cutaneous lupus. If this were left untreated, probably would move into discoid lesions, but if caught early, it can be treated and therefore avoid scarring. Obviously, a KOH would be performed to look for pityriasis versicolor on the face of that patient. Rarely one may see atypical lesions that are hypopigmented. Here are a number of other patients, all of whom look to have guttate hypomelanosis, but none of whom have IgH. And so I want to point out that on the shins, in the one patient with both shins showing, there is background hyperpigmentation. So it isn't strictly a patient with guttate leukoderma, but rather a dyschromatosis because there's both hypo and hyperpigmentation. But let me show you the diagnoses. Here you can see tinea versicolor, very important to do KOHs when lesions are on the face. The confetti lesions of TS, what about them? Well, they can surely mimic IgH, but the wrong age group when you see them. You shouldn't have a 6-year-old with IgH. The XP can be rather subtle, but think about a patient with severe photo damage. What do they have? Well, they have what I call Genoa salami skin. The fat is the IgH or white SKs, and the brown or the meat is lentiginate. So it's the same thing when you have premature aging of the skin and photosensitivity and photo damage, and that is that you get that mixture of lentiginase with the hypopigmentation. We have clear cell papulosis on the abdomen of a child, and as I said before, in the patient with cutaneous amyloidosis, we have the dyschromia, meaning we have both background hyperpigmentation as well as the guttate leukoderma. So I hope you've enjoyed this presentation where we went through disorders of hypopigmentation, went through diffuse, circumscribed, linear, and ended up with guttate, realizing that while IgH is a very common entity, we really need to have a broader differential, especially when the distribution is atypical, not just the shins and the forearms, or we do see lesions on the shins, but the patient is the wrong age for having IgH. Thank you very much.
Hi, I would like to congratulate the Guinea World Skin Health Day Congress organizers for having me today. Thank you. Today, I'm going to talk about melasma, give you some reviews and some news. I'm Van Jandog from Asian Hospital and Medical Center, Philippines. As for conflict of interest, I have none. We have to know the truths about etiology, melanogenesis, updates on topical and oral medications, and how chemical peel and lasers can be beneficial for our patients. On the other hand, ignorance, inadequate protection, and then irritation, allergy, ochronosis, and PIH and burn can actually lead to more expensive ways and might even be having some failure in management. So we have to do our best to improve the quality of life of our patient. Because having melasma can actually be very frustrating. I, for one, feel embarrassed and sad when my melasma recurs. It's a common pigmentary disorder with incidence as high as 30% in Asian women of childbearing age. It's consistently challenging. Complete history, correct diagnosis, dermoscopy, and even biopsy is imperative. Because what if it is lichen planus pigmentosus, Riehl's melanosis, or even a steroid abuse phase? We know that genetic predisposition plays very important role, as well as ultraviolet radiation and hormonal factors. But wait, there are more, like metabolic disorders, pro-inflammatory factors, procedural factors, and even psychological and neurological factors. Now, how pigment forms. This is a very busy slide of melanogenesis, but what I want to emphasize is that UV exposure produces free radicals, and then melasma has very high level of oxidative stress, and that visible light-induced pigmentation is more intense and stable compared to UVA. So let me focus on the blue and the violet light, which is between 400 and 465 nanometer. It activates a specific receptor known as opsin-3, located on the surface of the melanocyte. Opsin-3 increases the calcium influx inside the melanocytes, which ultimately leads to the production of melanocytic enzymes. So let's check it. Exposure to high visible energy light can lead to the stimulation of your opsin-3, leading to activation of your transcription factor, and then overactivation of your tyrosinase. Hence, protection from blue light can reduce melanogenesis, and this is really a bright idea. Solar radiation stimulates these cells to promote melanogenesis, keratinocytes, melanocytes, fibroblasts, endothelial cytes, and even your sebocytes. And so the signaling pathways, your Wnt pathway, alpha melanocyte stimulating hormone, and your stem cell factor. We see here the paracrine linkages between keratinocytes, your endothelial cells, fibroblasts, and melanocytes to produce or to enhance melanogenesis. Other factors to consider: pendulous melanocytes, basement membrane disruption, solar elastosis, and even neovascularization. Estrogen and progesterone increase melanogenic activity. In fact, in up to 75% of pregnancies, especially during the third trimester, it's due to increase in placental, ovarian, and pituitary hormones. This is just to show you that signals like your UV, irritation, injury, hormones, and radicals all stimulate melanogenesis through this pathway. And this can be inhibited by the red excesses. But I have summarized it. So before melanin synthesis, we can use antioxidants, anti-inflammatory agents, retinoids. And during melanin synthesis, we have the tyrosinase inhibitors, your peroxidase inhibitors, product reduction and ROS scavengers, and inhibitors of your inflammation-induced response. The text in blue are oral hypopigmenting agents. After melanin synthesis, we have the niacinamide, hesperidine, dioic acid, soybean. So what's new? let me introduce to you a new word, autophagy. What is autophagy? With an accent on the second syllable. It comes from the Greek words auto, meaning self, and phagy, meaning eating. It's a natural, conserved degradation of the cell that removes unwanted and dysfunctional components through a lysosome-dependent regulated mechanism. Ho et al. Suggested that autophagy could be activated to form autophagosomes that can engulf and degrade melanosomes. So here is how it goes. Your tyrosine and tyrosinase related peptide 1 are actually synthesized and transferred to your endosomes for storage and distribution. And then the endosomes transfer it to stage 1 or 2 melanosomes, which are then transferred into stage 3 melanosomes. And then here we know the pathway of your melanin synthesis. And the story goes stage 4 melanosomes being transferred to your keratinocytes. And so from the endosomes, excess peptides are then transferred to the lysosomes for degradation here. Okay, and lysosomes are actually specialized cytoplasmic organelles in the form of a bag or a vesicle that holds a variety of enzymes. So agents that induce skin depigmentation in an autophagy-dependent manner, I can recognize 5: ellagic acid, your beta-mangosteen, radiofrequency irradiation, resveratrol, and tranexamic acid. Let me tell you about some newer topical hypopigmenting agents. Thiamidol, which is a potent reversible inhibitor of tyrosinase. Methimazole, it's an anti-thyroid agent. Melanocyte peroxidase inhibitor, a tyrosinase inhibitor via copper and copper ion chelation. Cysteamine, it can inhibit your tyrosinase and peroxidase. It scavenges your dopaquinone, chelates iron and copper ions, and can increase intracellular glutathione. Deflutamide is a non-steroidal anti-androgen that blocks the action of your endogenous and exogenous testosterone by binding to the androgen receptor. Topical metformin in the treatment of melasma, 30% versus the triple combination treatment, Kligman. It was demonstrated to have a downregulating effect on melanogenesis via the inhibition of your cyclic AMP-related genes involved in melanogenesis. Another nice slide showing the safety and efficacy of topical metformin 30% cream versus Kligman's. Glycinamide hydrochloride, it can inhibit your melanin production very effectively by reducing the activation of your CREB and the gene expression of your MITF. A new tyrosinase inhibitor, melaphenone, can decrease tyrosinase activity by 56%. Tranexamic acid, both topical and intradermal formulation. It has a reversible inhibition of your plasminogen going to plasmin, which can actually decrease your arachidonic acid, decrease your prostaglandin, and therefore decrease your tyrosinase activity. How about botulinum toxin type A in melasma? It can suppress epidermal melanogenesis both through direct and indirect mechanisms. Proposed mechanism of actions of botulinum toxin, anti-inflammatory activity, which may affect various cytokines involved in pigmentary alterations. And it can also inhibit your acetylcholine release by the botulinum toxin, suppressing the alpha melanocyte stimulating hormone secretion. Actually, intradermal botulinum toxin can be beneficial as an adjuvant treatment that are aggravated by UVB. However, its role requires further elucidation. Other novel agents and techniques. The resveratrol from red wine or grapes can inhibit tyrosinase directly and indirectly, can regulate melanocyte function, and carries antioxidant and anti-inflammatory properties. PRP, platelet release of transforming growth factor beta from alpha granules can inhibit melanin synthesis. Microneedling has been postulated to lighten recalcitrant melasma lesions via the stimulation of collagen and elastin to diminish the visibility of dermal pigment. How about stem cell-derived exosomes? It could potentially treat melasma, but the skin barrier is a challenge. I thank my friend Dr. Cherry Abayo for lending me this slide, which after 3 sessions of microneedling and topical application of reconstituted lyophilized exosomes, there was improvement in her melasma patient. I want to emphasize the importance of antioxidants. As we all know, UV, trauma, pregnancy, stress, vaccination, even dehydration and lack of sleep can produce ROS. Increased oxidative stress has been shown in melasma, and that the serum levels of malondialdehyde, which is an end product of lipid peroxidation, are increased in melasma patients and correlate with the disease severity and disease extent. So this slide shows us the impact of antioxidants on melanogenesis. And the black and the green text are those good for melasma, namely your cysteamine, Polypodium leucotomus, silymarin, pycnogenol, tomato lycopene, and zinc. How about chemical peeling? Indication of which one of them is melasma. And the choice of peeling agents are enumerated here, but I want to show you the levels of evidence and strength of recommendations for various peeling agents in ethnic skin. Glycolic acid peel has good evidence, but lactic acid peel, salicylic, Gessner's, TCA will have a fair evidence of strength of B. Lasers. Laser therapies are not a first-line treatment for melasma, but instead should be considered in patients who have not improved with medical management. Low fluence Q-switch Nd:YAG is the gold standard laser for melasma in Asia and is well tolerated. The picosecond technology, its shorter pulse duration, stronger photomechanical effect, can break melanin into smaller granules with less perilesional thermal damage. Other lasers like your IPL and PDL are controversial and may have the risk of relapse, PIH, and melasma exacerbation. I want to emphasize here that topical tranexamic acid is being considered not only for mild melasma, but also as a maintenance baseline for mild, moderate, and severe melasma. So the strategies in the management of melasma, I have emphasized protection from the sun, especially from the blue light, reduction of melanocyte activity, your hormones, your thyroid disorder, removal of melanin through chemical peeling, the inhibition of your melanin synthesis because of your tyrosinase inhibitors, your peroxidase inhibitors, your antioxidants, and we have to address neovascularization through your tranexamic acid and the disruption of your melanin granules through your lasers. And so we can have success by evaluating our patient well, by patient education, first line of management, of course, the sunscreen, your topical and oral hypopigmenting agents. The second line will be your chemical peels and lasers. Don't forget the antioxidants and moisturizers and maintenance. And then probably we can have at least 90 to 95% success. The snail symbolizes tolerance and perseverance. It actually, very slowly, it can symbolize the process of management of melasma and therefore be able to help our patient improve their quality of life. Thank you very much for your kind attention.
Good. Morning, everyone. At the outset, I would extend my heartfelt gratitude and thanks to the organizers and the scientific team of Guinea World Skin Health Day Congress. And I would extend my special thanks to Dr. Ibrahim and Dr. Rashmi Sarkar for giving me this opportunity to speak on diffuse hyperpigmentation, a revisit. Now, to be honest, it's pretty difficult to cover the entire topic on diffuse hyperpigmentation within the stipulated time. I would try to touch upon the important aspects of diffuse hyperpigmentation. Say, what are the pigments which cause diffuse pigmentation? There are melanin, there is non-melanin, which can be iron, gold, bismuth. There can be mixed elements like your very metallic ions, and it can be because of some undetermined origin as well. So how do we confirm whether it's a melanin pigment only? We all know there is some Fontana-Mason stain, which stains that particular pigment. Of course, we can also go for MEL5 immunohistochemistry. Now, starting with the basics, etiological classification of diffuse hyperpigmentation can be broadly categorized into the following groups, starting from endocrinological to nutritional to metabolic, tumoral, physical, occupational, and various other causes. So if we start with endocrine causes, the important ones include Addisonian pigmentation, Cushing syndrome, Nelson syndrome, diabetes, of course, acanthosis nigricans, hyperthyroidism, and various other entities. So this is one you can see acanthosis nigricans in a background of obesity, the sides of neck, the nape of the neck is involved. There is a velvety rugose, thickening of the neck. You can see acanthosis nigricans like changes in the periumbilical area as well. So this was a patient of diabetes mellitus who presented with hyperpigmentation of the skin. Coming to hyperthyroidism, again, you will come across diffuse pigmentation. Apart from that, this is very typical of hyperthyroidism on the knees. You can see pre-tibial myxedema. Of course, this is a giveaway diagnosis. Coming to Addisonian pigmentation, you can see there is a generalized pigmentation, the pre-existing nevi, the pre-existing scars, they, become more pigmented. Very classically, there is more pigmentation along the crease of the palms. So that is something very classical and very hallmark of Addisonian pigmentation. Familial glucocorticoid deficiency, yes, apart from your diffuse pigmentation, you will come across various other changes starting from your cachexia and some other deranged metabolic and endocrinological parameters. This is rare. This is not a common thing. Pregnancy, of course, you have the linea nigra, you have a diffuse generalized pigmentation, which usually goes away once the delivery happens. Generalized benign acanthosis nigricans. This is one of the rare variants of acanthosis nigricans. You can see this we reported in Indian Dermatology Online Journal, where you can see this was an infant who presented with generalized thickening of the skin, generalized pigmentation, a velvety rugose appearance. Very classically, you can see the porcupine-like hands, porcupine-like palms and soles. So one of the closest differential diagnoses is ichthyosis hystrix in such cases. Of course, biopsy followed by histopathology clinches the diagnosis. So after endocrinological, you have nutritional where, kwashiorkor, vitamin B12 deficiency, niacin deficiency, they are the important causes. Metabolic causes, of course, porphyria cutanea tarda, hemochromatosis, Gaucher's disease, Niemann-Pick's disease, Wilson's disease, chronic renal failure are the important causes. This you can see visceromegaly, diffuse hyperpigmentation in a patient of hemochromatosis. Again, vitamin B12 deficiency, where classically you come across, pigmentation of the palms and soles, pigmentation of the dorsum of the hands, dorsum of the feet as well. And it usually responds very well to vitamin B12 injections. Then, of course, you have physical causes, that is exposure to ultraviolet radiation, ionizing radiation, trauma, and various other things. Very common, which we come across in our day-to-day practice, are the occupational causes, starting from your pigmented contact dermatitis, deposition of metal elements like your silver, mercury, gold, bismuth, and various other elements. I come from eastern part of India where chronic arsenicosis causing diffuse pigmentation, causing raindrop pigmentation, that is something very, very common, and we need to keep this in mind. So this is what I was speaking of. You can see different kinds of pigmentation in the photograph. One photograph shows the rain drop pigmentation. One photograph shows the mottled pigmentation. Another one shows diffuse pigmentation. This is diffuse pigmentation. Apart from that, you can see some pre-malignant changes as well. Some bovinoid lesions are there on the skin. So chronic arsenic poisoning is something which is very, very common in our part of the country. And this is because of the Ganges River, which flows across the eastern part of India. And because of the population consuming tube well water, the ground well water, there is ingestion of arsenic, and chronic exposure to this arsenic metal causes a lot of skin changes. Generalized argyria, of course, this is not very common, but of course, if you get this bluish kind of line along the lunula of the nail plate, that is something very, very diagnostic. Coming to etiological classification, this again is coming to the medication-induced causes. This is again very, very important, especially because in India, leprosy is very common, and clofazimine is one of the drugs which is responsible for diffuse pigmentation. If we think of antiretroviral drugs, again, zerovurin is one common cause. There can be amiodarone-induced, minocycline-induced, anti-malarial-induced, that is chloroquine and hydroxychloroquine. Apart from that, newer drugs like your imatinib, then your epidermal growth factor receptor inhibitors, they can also cause a very peculiar diffuse pigmentation. So this is one patient who was suffering from leprosy, and you can see there is a diffuse pigmentation due to clofazimine. This one is very classical of bleomycin-induced flagellate pigmentation. I'm sure this is a very giveaway diagnosis. Apart from that, exogenous ochronosis, again, that can be an important cause of diffuse pigmentation. Then you have miscellaneous causes where the list is huge, starting from your lichen planus pigmentosus, ashy gray dermatosis. Now, all these things are usually now combined under an entity, an umbrella term, which is called as acquired dermal macular hyperpigmentation. Apart from that, there can be universal acquired melanosis, that is carbon baby syndrome. There can be some genetic causes like your extensive Mongolian spots. There can be adrenoleukodystrophy. There could be familial progressive hyperpigmentation, Poems syndrome, Cronkite Canada syndrome, and various other causes. So this, of course, this is the broader term now is ashy acquired dermal macular hyperpigmentation, and this is ashy gray dermatosis, as you can see. This chromatosis universal is hereditary, again, a rare cause, but important to be diagnosed because here you can come across both hypo and hyperpigmented lesions all across the body. Generalized fixed drug rash, this was again one of our cases, which was a doxycycline-induced generalized bullous fixed drug rash. And here you can see when the lesions healed, they led to an almost generalized diffuse hyperpigmentation. Tanning, of course, there can be diffuse pigmentation. Familial progressive hyperpigmentation, yes, this is rare, but of course, the family history, presence of a mottle-like pigmentation on the palms, on the dorsum of hands. Very classically, there is pigmentation of the lips, as you can see, pigmentation of the tongue as well, oral mucosa as well, which is a clincher when we want to diagnose. Systemic sclerosis, of course, though salt and pepper kind of pigmentation is the classical finding in such patients, but yes, diffuse hyperpigmentation can also be there. Onchocerciasis, this is where this is a neglected tropical disease, but yes, this can again present with diffuse pigmentation. Apart from that, you can come across different other skin changes like your lizard skin, leopard skin, and various other kinds of cutaneous manifestations. This is again HIV-associated hyperpigmentation. It can be not associated with your zerovurin pigmentation. So in HIV patients, the pigmentation can be because of the virus itself, because of the disease itself, and it can be because of zerovurin also. So how do we approach a case of diffuse hyperpigmentation? Basically, we just approach, we start from the history, we examine the patient, we investigate, and finally go for the treatment. History, of course, we need to see whether it's physiological pigmentation or a pathological pigmentation. As I mentioned, pregnancy is a very important cause of physiological pigmentation. Tanning, again, is a common cause. If we think of onset, if it's present from birth, it could be carbon baby syndrome, it could be extensive Mongolian spots, it could be other genodermatosis. Disorders like your ashy gray dermatosis, kwashiorkor, idiopathic eruptive macular pigmentation, that is again very important and very important to diagnose. That is usually common in childhood. Most of the other causes like your metabolic drug, systemic sclerosis, lichen planus pigmentosus, usually present in middle age. Elderly, of course, this is not very common. If an elderly patient is presenting with a sudden onset generalized hyperpigmentation, we need to think of some of the unfortunate causes like your malignancy and CTCL. So this is a picture of, you can see two siblings with the universal acquired melanosis, that is carbon baby syndrome. Sex, of course, I don't think there is any gender predilection when it comes to diffuse pigmentation. Residence, of course, as I mentioned, chronic arsenicosis, my part of the country where, the river Ganges is flowing. So this is one of the very important causes. If the pigmentation is very acute, we need to think of paraneoplastic causes. We need to think of idiopathic eruptive macular pigmentation. We need to think of Gaucher's disease. We also need to think of post-chikungunya. Suppose the pigmentation is reducing with age, it could be a good thing, that is a Mongolian spot. If it is increasing with age, it is usually miscellaneous causes. It is usually metabolic causes. This one you can see idiopathic eruptive macular pigmentation. Again, this is a diagnosis of exclusion. There are certain diagnostic criteria beyond the scope of this presentation. Of course, past history in such patients is often a clincher when it comes to diagnosis. If there is a history of, say, spotting or staining of napkin, it goes in favor of alkaptonuria. If there is fatigue, loss of energy, we need to think of Addisonian pigmentation. We need to think of kwashiorkor. Of course, post-chikungunya pigmentation is very common right now. Over the last 2-3 weeks, I think I have seen more than 30 cases of post-chikungunya pigmentation in our country. And patients usually have a history of very high fever, severe joint pain, and following which this pigmentation comes up. Of course, pigment contact dermatitis and Reels melanosis is very important when the patient is applying cosmetics or fragrances. This, as I was mentioning, is a case of hyperpigmentation due to chikungunya. You can see there is a very classical deep pigmentation in the nasal area, and this is known as the chick sign. Pigment contact dermatitis, this is something very common with fragrances, very common with hair dyes. Important past history we need to take care of, whether there is a history of atopic dermatitis, whether the patient has recovered from a psoriatic erythroderma, whether there was an episode of Stevens-Johnson syndrome. All of these disorders can lead to a diffuse pigmentation. Of course, if you are thinking of hemochromatosis, you need to rule out underlying diabetes-associated symptoms. If you're thinking of porphyria cutaneous tarda, you need to take care of photosensitive lesions, fluid-filled lesions, fragile skin. Wilson's disease, of course, the neuropsychiatric manifestations and chronic liver disease is something which is going to be very handy. Gaucher's disease, of course, easy fatigability, bruise, jaundice, that is important. If the patient is having a diffuse pigmentation in a background of renal failure, that needs to be taken care of because it usually responds to taking care of the urea creatinine. Wilson's disease, as I was mentioning, there are neuropsychiatric abnormalities. There is a defect in the musculoskeletal system as well. Of course, you get the KF ring also. Again, systemic sclerosis, as I mentioned, there could be other features like your Raynaud's, dyspnea, esophageal reflux. If you're thinking of pheochromocytoma, that is a very grave thing where headache, sweating, palpitation, all these things are important. And of course, if there is a very rapid onset diffuse pigmentation, we need to think of some of the unfortunate rare causes like your gastric CA, thymic CA, carcinoid, and all the other malignancies. So these are the important entities which need to be remembered. Whenever we think of a family history associated with hyperpigmentation, all the genodermatosis, all chronic arsenicosis, familial progressive hyperpigmentation, and some other metabolic causes. So this is a very interesting case of chronic Canada syndrome where there was alopecia, where there was nail dystrophy, where there was there was a diffuse pigmentation, there was a history of diarrhea. So this is not my case. I've taken this case from internet. OM syndrome again associated with your underlying multiple myeloma or monoclonal gammopathies. Clofazimine-induced coppery red pigmentation, as you can see, this is something very common in our country because leprosy is very much prevalent here, and clofazimine is one of the go-to drugs when you think of leprosy, and clofazimine-induced pigmentation is something very, very common. Coming to general examination, of course, it is not very handy when it comes to diagnosing a case of diffuse pigmentation, underlying cause of diffuse pigmentation. But still, yes, certain points like icterus, it goes in favor of Wilson's or hemochromatosis. Presence of hypertension, that is something not good because it could be because of underlying Cushing's or pheochromocytoma. A certain important diagnostic clinchers, say the involvement of pre-auricular area and the temple region which is progressing towards the limbs. This goes in favor of lichen planus pigmentosus. As I mentioned, typical involvement of the acral regions, digits with sparing of the nail beds, this goes in favor of vitamin B12 deficiency. Say involvement of the face, the pinna, the tip of the nose, it goes in favor of chikungunya. So meticulous clinical examination always clinches the diagnosis. So this is, as I mentioned, a very classical case of lichen planus pigmentosus. You can see the pre-auricular area in the gentleman is very typically involved. Again, one of our cases which we reported, this is the pigmentation of the tip of the nose. In chikungunya, you can see, and this is known as the chick sign. Yes, again, if there is typical involvement of the cartilage, the axilla, the sclera, the conjunctiva, we need to think of alkaptonuria. If there is involvement of the frictional areas, the scars, the palmar crease, the nipple areola, we need to think of Addisonian pigmentation. So this is a very typical Osler's sign. You can see there is involvement of the cartilage, there is involvement of the eyes. This is alkaptonuria. Color of pigmentation, I'm not going into the details because we belong to skin of color. In our skin, it is very difficult to appreciate different kinds of colors unless the Fitzpatrick skin type is towards type 2 or type 3. So this is the very typical color of lichen planus pigmentosus. So if we get this kind of color in our day-to-day practice, we are very lucky. Unfortunately, out of 10 patients, I don't think hardly 1 or 2 patients will come with this kind of color. Minocycline-induced pigmentation again is very common because minocycline is used as an anti-acne drug. This is a very effective drug. It leads to different kinds of pigmentation. The acne scars get pigmented. There's pigmentation of the dorsum of the feet. There is pigmentation of the shin. There is pigmentation of the forearms, the sun-exposed areas. The jet black discoloration in carbon baby syndrome again is very classical. Additional cutaneous findings often help in diagnosis, say if you are getting features of hypercorticism, if you're getting features of hyperthyroidism, if you're getting features of Wilson's disease, specifically your KF ring, which I had shown a photograph, azure lunula, they go in favor of Wilson's. If you're coming across sclerodermoid changes, it goes in favor of PCT. If you're coming across black stasis dermatitis, it goes in favor of hemochromatosis. So here you can see there is hyperpigmentation, there is scarring, there is milia formation, which goes in favor of PCT. Not my case, a very unfortunate case of melanosis of malignancy. There can be additional skin findings which help in diagnosis. This, which I was mentioning, very interesting. Patients of chronic arsenicosis, they come with bizarre pigmentation. It could be a diffuse pigmentation. Very classically, they present with this kind of, pits on the palms and soles. We call these as keratotic pits. Now, these pits are categorized into mild, moderate, and severe, depending on the size and the confluence. So this is something very typical of chronic arsenicosis. Almost every day we come across 1 or 2 patients of chronic arsenicosis in our practice. Pellagra, again, of course, you must be knowing, you get the sun exposed area involved, you get the Casals necklace, you get gauntlet of pellagra and different kinds of things. Nail involvement, yes. If you get Murke lines, you get terry nails, it goes in favor of CRF. If you get a pale blue lunula, it goes in favor of endocrinological causes. If you get Mees lines, it goes in favor of chronic arsenicosis. If you think of Wilson's disease, you need to definitely search for azure lunula. If you are thinking of HIV, you need to think of white superficial onychomycosis. Coming to investigations, of course, Wood's lamp is a very handy thing, not done routinely, but yes, it of course helps in differentiating whether it's a epidermal pigment, whether it's a dermal pigment or a mixed pigment. Histopathology will help us in diagnosing the nature of pigment, whether it's melanin or non-melanin or something else. What is the location of the pigment deposition? It's epidermal or dermal or both, and whether there's a concomitant increase in the number of melanocytes. So this is how we classify. Say you have increased epidermal melanin, along with that you have increased number of melanocytes. It could be because of radiation, it could be because of tanning, it could be because of PUVAR therapy. If you have increased melanin with a normal melanocytes, you need to think of some pregnancy causes, storage disorders, specifically Gaucher's, hyperthyroid. Suppose you get both increased epidermal and dermal melanin, you need to think of some of the important causes like your nutritional deficiencies, endocrinological causes, carbon baby, autoimmune, some rare causes like your primary biliary cirrhosis. If you are thinking of increased pigment deposition within the macrophages, this is mostly a drug-related cause, which could be a phototoxic drug reaction or a photoallergic drug reaction. Histopathology, of course, this definitely helps. Lichen planus pigmentosis, as I mentioned, there is basal layer degeneration, there is pigment incontinence, there is melanophages, there is the typical findings of lichenoid dermatitis. Acanthosis nigricans again, so facial acanthosis nigricans, this was reported by our team in Indian Journal of Dermatology, where we reported this facial acanthosis nigricans is a morphological marker of metabolic syndrome, and histopathology is very much diagnostic and suggestive in such cases. If histopathology is not available, we can go for dermoscopy also. Now, pigmentation could be because of non-melanin causes. It could be because of bilirubin. It could be because of carotenoids. It could be because of iron, say in hemochromatosis. It could be because of lipofuscin materials, specifically in your clofazimine-induced pigmentation. Of course, it could be because of drugs, specifically your chlorpromazine. Argyria, as I mentioned, there is deposition of silver around the sweat ducts. There is, very typical bluish change in the nail. Dermoscopic clues, that is something very, very important. You get exaggerated pseudoreticular pattern, you get a jelly sign. These go in favor of causes like melasma and some other causes of facial melanosis. So if you get something like this where you're suspecting exogenous ochronosis, you need to see macular depigmentation, which is accompanied by a speckling. You could see grayish brown amorphous structures in the perifollicular regions, which is obliterating the follicular openings as well. If you think of lichen planus pigmentosus, you need to come across bluish gray pigment deposits. If you're very lucky, you will see a hem-like pattern, which is shown in the photograph. If you're thinking of acanthosis nigricans, you can come across thristy and sulci, which is very classical of acanthosis nigricans being on the face, on the neck, or any other part of the body. If you're thinking of, say, periorbital pigmentation, you will get mostly an accentuated pseudo network. Coming to treatment, very difficult to treat, may not be that difficult to diagnose. When it comes to topicals, we go for steroids, we go for calcineurin inhibitors. If you think of systemic treatment, again, immunosuppressives, you have methotrexate, you have colchicine, you have hydroxychloroquine, various other causes. Lasers, yes, not much good results. PCT, of course, you need to remove the precipitating factors. You need to think of sunscreens. You need to think of iron chelating molecules like your desferrioxamine as well. Alkaptonuria, again, difficult to treat. Now, vitamin B12 supplementation and vitamin C supplementation often helps. Nitisinone is one drug which blocks homogentisic acid production, and it could be helpful in patients with alkaptonuria. Addison's disease, yes, it is a multidisciplinary approach where you need to liaise with your medicine colleagues, internal medicine colleagues, endocrinology colleagues. They would help you. Vitamin B12 pigmentation, yes, it responds very well to intramuscular B12 injection, 1 milligram per week for 1 month, followed by 1 milligram per month till reversal. I'll show you photographs. The results are usually excellent. So this is how patients do respond to vitamin B12 supplementation. So I would just like to summarize by saying that diffuse hyperpigmentation can be caused by huge number of causes, starting from physiological to metabolic to endocrinological to absolutely acquired dermal pigmentation causes to malignancies to nutritional various causes. We need to have a very good clinical eye to suspect an underlying systemic disorder, whether the patient needs to be referred to other specialists or not. So we have to have very good clinical eye. We have to do a very meticulous mucocutaneous examination. We need to investigate the patients properly so that the patients do not run from door to door for getting a diagnosis and a proper treatment. So this is my
Dear colleagues, thank you for this prestigious invitation to discuss with you what's new and what's true today in vitiligo. This kind of lecture is covered by the Journal of Applied Cosmetology of the World Health Academy Publishing House. First of all, I would like to share with you one information. Please take a picture of this slide and always follow the Vitiligo Research Foundation organization. This is the organization of which I am the co-founder, and presently I serve as president of the Executive Scientific Committee. It is based in New York, Penn Plaza 1, and it offers free of charge updated guidelines in 37 different languages, and up to now we have got 70 million accesses. So, to be updated on vitiligo, this is what you really need. And if you will follow this kind of information, you will always be updated and we will always be in touch. My first recommendation: each and every treatment for vitiligo needs time for repigmentation. In this time, people cannot stay with the discomfort of the contrast between the white area of vitiligo and the apparently normal skin. In my department and in my the camouflage showing. In this way, the patient, independently of the age, will be treated for the time needed for getting repigmentation and will have a normal social life, because thanks to a good camouflage, it will be a perfect combination for treatment. We have contributed with our publications on new concepts and new therapies, and I insist with you on the concept that a good camouflage, but must be good. I mean that we need to train professionals for this, will help us and the patient in getting repigmentation in the time which will be needed in the best conditions. Never think of the so-called semi-permanent camouflage. This is something that has nothing to do with camouflage, and it is extremely effective in vitiligo, but I have seen too many troubles in my long academic and medical career. So I would not recommend to you the semi-permanent or permanent camouflage. Well, till few months ago, there was not any kind of drug which was officially approved for the treatment of vitiligo. I mean that each and every expert, each and every doctor, each and every dermatologist was using only off-label treatments for vitiligo. Why off-label treatments? Because there was not any approved treatment. Things changed in the beginning of the year 2024, in the spring, when for the first time ruxolitinib, a cream which is now on the market with the name of Opzelura, was approved by the Food and Drug Administration. This drug is a Janus kinase inhibitor, concentration 1.5%, can be used only for children after the age of 12 years and should be applied locally only in the forms of non-segmental vitiligo 2 times per day. So, a cream, age only after 12 years, and treatment localized 2 times per day. For how long? Well, 6 to 9 months. If there is no repigmentation, it means that we should start with some other strategies. This is as I was telling you, Janus kinase inhibitor, but it is not the only one. Already we discussed in the past, this is one of our publications, the use of Janus kinase inhibitors, and we proposed, and I still propose to you, the use of combination treatments. I mean that we should not only use, for example, this cream, this Janus kinase inhibitor, but we can add, in the non-responding cases, creams or ointments with calcineurin inhibitors, or some type of surgical modalities, or, for example, the so-called weekend therapy with 2 milligrams prednisone of corticosteroids, for example, in the weekend, for 3 to 5 months. This kind of association in our hands gives the best result for different patients. Here you can see some of our papers. I am showing to you because they are free articles. You can download free of charge, and you can find an enormous amount of information about the different applications of different treatments to different people, different kind of skin, including the so-called ethnic skin, and at the different ages of subjects affected by vitiligo. Again, you can see other papers from our team, and one which is interesting, the use of simvastatin, which is used in general for reducing, lowering the cholesterol levels in subjects with hypercholesterolemia, and it proved to work by activating the Janus kinase pathway. How to choose the phototherapy or the therapy for a subject with vitiligo? Well, I think that first of all, we should think of age, comorbidities. For example, the presence of Hashimoto thyroiditis, the compliance. Different patients have different compliance. And the proposal of the FDA-approved drug, but also taking into consideration unlicensed treatments, which sometimes can be more efficacious and more recommendable than the others. And then other possibilities of approach, for example, with the pseudocatalysis, with Photocell. We will see what they are in a short while. Lights. I would say that today PUVA treatment cannot be used any longer because in Western Europe at least, oral psoralen have been banned. They cannot be used, and because of this, PUVA therapy is declining and cannot be used any longer. And the other lights, for example, the PIC F311 or 308, they work better if they are focused. You will see in a while what I mean. We have also discussed the possibilities of different combined treatments, including treatments which are belonging to the field of integrative dermatology, because some subjects they request an holistic approach which is not limited to the medical strict approach for repigmentation. hyperpigmentation. And here you can see the new phototherapy. I was telling you that PUVA therapy, which is a total body exposure, is no longer recommendable because there is an increase in contrast between the apparently normal skin and the vitiligo skin, the white skin. So in this way we created at the end of the last millennium this device which was able to bring directly to the white spots either the highest level of satisfaction in treatment of vitiligo. This kind of something that we created around 15 years ago, and it is a sunscreen with a sort of window. This window permits the arrival to the skin of the 311 nanometers peak. As you can see in the picture, the repigmentation is both perifollicular and interfollicular. And as you can see in the picture in the bottom, sometimes we get a sort of absorbance of our invention, and you can see how the Dead Sea irradiance and our cream irradiance have a very similar overlapping peak. And here, just as a sort of summary, you can see the different type and the evolution of treatment. No more PUVA therapy, excellent treatment with focused therapy with the bioskin evolution, excellent treatment with localized excimer light or excimer laser, and last, this is the most, I would say, the most prestigious and the most effective and safest way, the so-called UV1 irradiation with a laser which emits at 355 nanometers. We have this in our clinic, and I must tell you, we have excellent results. Well, I told you about the signature of the interferon gamma and the JAK inhibitors. I told you that there is not only ruxolitinib, there is tofacitinib, and soon in the market there will be other NIB, for example, ifidaucitinib, or other similar Janus kinase inhibitors with different names and different, slightly different way of action on the skin translation. Well, this is my friend Karin Reuter, and she was using for a long time the pseudocatalyse which were unstable. So they did work in her end at the Dead Sea, but for the rest, nobody was able to use this kind of treatment because being it is unstable, it was impossible to transport far from the local place where it was used. In the future, we can envision activity with the small molecules on the regulatory T cells and some special attentions for the children, for the use of treatment, topical and systemic treatment for the children, and we have dedicated several papers to the treatment of vitiligo in pediatric age. All these papers which you see can be downloaded from you free of charge. Well, we are now reaching the end of my presentation. I didn't share with you all what is new, because most of what is new is still in the pipeline. But I decided to tell you what's true. And what's true is that we have a FDA, the first FDA approved treatment, the cream, lutoriximib, 1.5%, but still combination treatments, which I have shared with you, remains my personal choice in the best interest for the safe and for the effective treatment of our patients. And there is a new journal, International Journal of Pediatric Dermatology. There are many papers devoted to vitiligo. We were working in the creation of this journal. I hope that you also will enjoy it. And from the World Health Academy Publishing House, which is now 40 years old, I thank you for your attention.
Disclosure, I'd like to talk to you today about Trachyonychia, rough nails. Trachyonychia is a sign of nail dystrophy, but it's believed that this term, however, is not appropriate anymore and must be abandoned, as the dystrophies do not always involve all the 20 nails. It's more frequent in children, where it usually affects all the 20 nails, but it can occur also in adults and affect just few nails. As you can see from this picture, just 2 nails are affected by the disease. The average age of onset is 3 to 12 years old. So as I said, it's very common in children. It's more common in children than in adults. And fingernails are affected more often than toenails, even if toenails are more severe. So the disease in the toenails, probably due to the trauma in wearing the soles, is more severe. There is a male preponderance in children and a female preponderance in adults. Clinically, we talk about trachyonychia as a sign when the nail plate shows thinning and, above all, roughening due to multiple longitudinal ridging and superficial scaling. Hyperkeratosis of the cuticle is often present. Also, koilonychia may be associated, and it's a painless sign. So there are no associated symptoms. As I say,